Hi, welcome to PT Snacks Podcast. In this case, your host. And if you're tuning in for the very first time, what you need to know is that this podcast is meant for physical therapists and physical therapist students who are looking to grow your fundamentals in bite-sized segments of time. Now, today, we're going to dive into a topic I feel is very important for physical therapists to understand. It's the fact that not all rotator cuff tears are the same. One person could have a rotator cuff tear and another could have a rotator cuff tear, and they could each have a very different prognosis. So for us to be able to understand what those differences are can help either at least set up our expectations, build an understanding of some factors that might go into someone's healing potential versus another based on the person, based on the tear, all that kind of stuff. So the more we can understand that, the better we can be and the more specific we can be to helping that patient the best that we can. So with that, today we're going to dive into just a brief review of what makes a tendon, and then more specifically go into around the rotator cuff, different types of tears that there are and how they do. So before we dive into too much, if you have been listening to this podcast for at least 3 episodes and you feel like it's really been helpful, if you wouldn't mind just pausing really quick and leaving a review wherever you listen to this podcast, that would be so helpful for me. That really does help grow the show a lot. And I really do read all your reviews. So I really appreciate those who've taken the time out of their day to do so. Now, with that being said, let's dive in. So what's a tendon? So a tendon is a very highly organized, mostly avascular connective tissue that their job is basically force transmission. It has a very specific hierarchy of collagen, of specialized cells, an extracellular matrix, all that help it to be able to do its job. So when we're diving into the smaller components within a tendon, we have type 1 collagen, which is the dominant load-bearing component, and it's layered into fibrils, which may then combine into fibers. Then they combine into primary, secondary, and tertiary bundles, and then eventually make up a whole tendon. So there's lots of layers within layers in each other. And then there's also smaller amounts of collagen that help to regulate fibril packing, assembly, higher order structure, stiffness, and they help connect tenocytes to the matrix itself. So basically helping it to do its job better. And with this sort of structure, the neat thing about it is it helps the tendon to be able to tolerate all different types of stress, whether it's tolerating tension, shear, rotation, all that without the structure failing. So when we are diving into what cells make up our tendons, we have tenocytes and tenoblasts. And these are elongated fibroblast-like cells that are in between collagen fibers. And they help to maintain the extracellular matrix, or ECM for short, and respond to load. And their shape, the process, the alignment, all that help to basically regulate fibrinogenesis and fascicle formation, essentially making of new cells that keep our tendons as they are, right? Now, within the tendon, we also have the non-collagenous ECM, or extracellular matrix again. So we have proteoglycans and small leucine-rich proteoglycans to control collagen fibrinogenesis, fibril diameter, intrafibrillar glue, in a sense, hydration, viscoelasticity, elastic fibers, and then even within that interfascicular matrix or endotendon and epitendon and peritendon that have collagens and non-collagenous proteins and vessels and nerves. And all of these structures help with sliding between fascicles and the biomechanics and healing of a tendon. In terms of vascularity, the tendon is not very vascular, it's mostly avascular. And that matters because that is going to affect how well it heals. We know that we need blood flow to help transport the specific chemicals that help to kickstart that healing process, and also to be able to clear some things out that shouldn't be there. So tendons get a lot of their nutrition from either the myotendinous or osteotendinous junctions and surface tissue, which means that they have low vascularity areas that can limit healing capacity just based on what part of the tendon is not getting it. So a lot of these tendons will get a lot of their nutrition from either the myotendinous junction or the osteotendinous junction and the surface tissue. It's an important note because there are some aspects of tendons that don't have great blood flow and then therefore don't have great healing potential. So very, very important to understand. What causes tearing? So there are different types of tears that can happen. One in particular could be degeneration or could fall on a continuum of tendon degeneration. Now, in terms of tendon degeneration, we're going to talk about a tendinosis where we basically see improper healing, an improper healing response to where over time that can lead to, if we're looking at the rotator cuff specifically, partial thickness tears. So if we're defining what partial thickness tears are, if you picture my hand right here, I'm holding it up as the cross section of a tendon. So we're talking about the tips of my fingers all the way down to the palm. If I cut through, maybe we'll say halfway, I have not cut through the entire cross section. That would be a full thickness tear. I have cut through partially, so it's a partial thickness tear. Some fibers are intact there. Now, those in the shoulder, we'll talk about that in a moment, could be articular or bursal-side of rotator cuff tears. And eventually they could progress into a full thickness tear. We've cut completely through the cross section of that particular tendon. That progression is especially common in partial thickness tears that are high grade, meaning that more than 50% of the tendon is torn. So with that greater tear, it tends to put more stress on the tendon already, and the rest can follow, essentially. So degeneration, we'll say it like that. Other categories can be from trauma. So I had a patient once who fell through their ceiling, their hand grabbed onto a beam, and then because of that rapid deceleration of their body, when they caught themselves on their arm, they had a rotator cuff tear. That is an acute trauma, very unfortunate. Or you'll hear of people cleaning their gutters and they fall off their ladders and they're hanging on or things like that. But essentially, it's from either like a fall or an eccentric sudden loading that causes an immediate full thickness disruption. It's like, it's gone. So category 2. Now, there are also people who are a little bit more predisposed to developing rotator cuff tear. So older age, we know that it is very common for people who are older to have rotator cuff tearing show up on their imaging, and they may be asymptomatic. They have no idea it's there. That's very, very common. But we do see a correlation between older age and rotator cuff tears. Smoking affects our healing capacity. So if your patient is smoking and you are treating them really for anything that requires good healing, especially like maybe they're coming to you post-op, they probably have already been recommended to stop smoking, but maybe no one's been able to explain why that's so important. And I do have an episode explaining more on that somewhere back in the depths. Hypocholesterolemia, high cholesterol, hypertension, the use of their dominant arm. Basically, you're using it more, so it's more exposed to stress. Genetics can also play a role, and unfavorable bony anatomy, which we'll talk about here in a second as well. So now we've determined what tears there can be, but let's dive in a little bit more with more detail explaining what that means. So partial thickness tears, again, it's only gone partially through the tendon, not fully. We can have articular-sided tears and bursal-sided. When I'm talking about articular-sided rotator cuff tears, this is more of the superior aspect where the supraspinatus tendon inserts into the humerus, the greater tubercle of the humerus. This tends to happen with intrinsic degeneration and hypovascularity. So there is a zone of poor blood supply on the articular side that makes this weaker. We also have layered anatomy and shear stress in this particular area. So our supraspinatus and our infraspinatus complex are layered. And then the articular aspect includes the capsule and ligament with a thin tendon portion. So it's a little bit more vulnerable to tensile load and interlayer shear. There's also delamination zones where the layers intersect and are a proposed starting point for where these tears really start to happen. But strain concentration with partial tears here that go beyond 50%, as I was saying before, of the tendon thickness can increase strain significantly. So movements like arm abduction with partial articular tears increase intratendinous strain and can encourage extension. So poor blood supply in that area just kind of predisposes it to not healing as well. Now, on our bursal side, these tend to be reported as a lot more painful. Bursa is a huge pain generator in the shoulder, and really the shoulder has a lot of nociceptors that can register pain, as your patients will probably tell you. Maybe not the nociceptor part, but the pain part. And within the bursa, it has a lot of nerves and free nerve endings. And histologic studies, they've actually shown that inflamed, thickened, and edematous bursa strongly track with higher pain scores. So we see this often linked to subacromial impingement or subacromial pain syndrome. Impingement is the older term. Pain syndrome is the newer term that they're utilizing. Acromial spurs. The theory of this is where there's repeated contact between the tendon and the chromion or coracoacromial ligament that has degenerated with time. So in essence, with the side, things like spurs, hooked acromion or acromial changes, subacromial narrowing, generally extrinsic factors. These are things where there's something actually pushing on the tendon and creating tears in that way. And naturally, bursas take up a little bit more space too, and they are inflamed and a little bit bigger. So, yes, it can be painful. Now, full thickness, we see again full discontinuity of the tendon. It can be small, it can be massive, like multi-tendon. These don't really tend to do as well, but it depends on the patient, how well good they are at healing, what they need to get back to, things like that. There are also tears that are classified as massive or irreparable, which is referring to more, it involves 2 to 3 tendons with retraction, fatty infiltration, and joint changes. Just a few other terms too that you may see on maybe surgical reports or just in research studies. There are patterns of tears. So usually these are more so used to guide repair techniques that are used rather than like for prognosis alone. But some of those terms are crescent, U-shaped, L-shaped, symmetry, extension. So all those are basically describing what shape it is, essentially. Now, in the clinic, how do we pick up on this? Now, there is some overlap between these different tears and what they'll look like, but generally, the larger the tear, the larger the dysfunction, generally. Now, so for instance, someone coming in who has a partial tear, you may not know this information already, but they may have pain, stiffness, painful arc, night pain, which I feel like most shoulder diagnoses have some sort of night pain. Often they may be more painful than full thickness. And if you think about it, it's full thickness, it's completely cut through. Partial, there is still some connection there. So can be a bit more painful. There's likely weakness, especially in the supraspinatus and external rotators. Remember that this generally supraspinatus, unless it's traumatic, tends to show tears first, and then our external rotators, etc. Many could be asymptomatic, as I mentioned before, but can progress to full thickness, especially if the tear is already greater than 50%. Full thickness, they can have pain. They may have less pain than partial thickness. They will have probably reduced strength and function. Some can be completely painless, and they have found both non-operative and operative can see a lot of improvement with physical therapy. It just kind of depends on where they're at. massive, there's massive repairable and massive irreparable. So massive repairable, we're talking about significant weakness, loss of elevation, external rotation, pain. It's variable. It could be really painful again. It could be not painful. And early repair can really improve function in these patients. So catching it sooner, really good. Now, massive irreparable, that's where we might see more chronic pain, dysfunction, usually degenerative in component. Non-operative patients can retain function. Again, it depends on what function they're trying to get to. Some of these patients may not be a good candidate for rotator cuff repair. That's where maybe we're looking at a total reverse shoulder or something like that. So in terms of outcomes, these can depend a lot on age, the tear size, fatty infiltration, muscle quality, and chronicity. These can all affect healing and prognosis. So age, we already mentioned, older, these might be more degenerative. It's a little harder to repair degenerative tears rather than an acute one that has not been retracted very long or is already a good muscle quality. There's not been enough time for fatty infiltration to happen yet, versus muscles with higher fatty infiltration that just don't quite have as good quality of tissue to work with when we're trying to heal. When someone has a degenerative tear, it does not necessarily mean that their symptoms are going to get worse, even if they get bigger. There's a little bit of redundancy with where all these muscles work together to create a force couple to help us to be able to lift our arm with a ball and socket joint. So we can see a variety of results, even if maybe on imaging it looks pretty poor. So then that being said, there are some tears where physical therapy can only go so far. But in terms of some good predictors of success, so that patients come in to see you, it's the first time and you're not sure if they're going to be a good candidate for surgery or maybe try conservative. A lot of times people, if it's not acute, they'll try physical therapy first, conservative approach. But they have found that with regards to range of motion and strength, in full thickness tears, good abduction, active range of motion, and strength at baseline predicted better long-term results. And then if they preserved external rotation, range of motion, so greater than 52 degrees, and strength, these were also good, strong predictors, which also kind of go into what we were talking about before. If you have a large tear, it's probably going to be hard to get your arm overhead. And it's also going to be hard to have good strength. And if you have a lot of fatty infiltration and things like that, it'll also be hard to have good strength scores. So it kind of gives us an idea of some of those factors that I just mentioned before. In terms of patients who had surgery and their outcomes, I'm not going to dive into that a lot this episode, but they did find that these patients can have great improvements in their range of motion and strength at midterm and long-term follow-up. Re-tears were associated with worse pain in strength and shoulder scores than healed repairs, but the differences were below clinically important thresholds. In traumatic tears in younger patients have better functional outcomes than chronic non-traumatic tears. So kind of goes into what I was talking about before. In terms of other methods for treatment, two that I looked into were steroids and PRP injection, platelet-rich plasma injections. Those are two that I tend to see the most. If there are other forms that you're seeing in your patients, let me know and I'll look into it. Steroids were found to have good, rapid, short-term relief, but repeated use is associated with tendon weakening and rupture risk. So may not be something that we want to lean into with the episode we're talking about rotator cuff tendon tears. PRP, it was found to be generally safe and have few adverse effects from it. And some studies even showed that there was a reduction in partial tear size on an MRI, but the protocols that are in place right now for PRP, the administration of it, the PT afterwards, they're really variable right now. And so it's really hard to be able to look at a lot of consistent data and be confident in specific results, but so far promising. The downside is the cost is higher. So not everybody can afford that. So all that to say, here's some highlights that you should have gotten from today. And if you didn't get that, either I did a horrible job teaching it, which is possible, or maybe you want to go back and listen to it again. You should be able to answer these questions. What is the tendon's job? What is its main job? And what are some components of it that help it to do so? What are the main types of tears that can happen in the rotator cuff? We'll even dive into partial tears. What are the two different types of tears that you can see on partial tendon rotator cuff tears? And then what are some factors that can go into how well someone heals after a tear, whether it's someone who went through conservative treatment, surgical treatment, that kind of stuff. You should be able to tell somebody that today. So if you have any questions, feel free to reach out at ptsnackspodcast@gmail.com. If you are looking for a specific topic to go over, let me know. Message me. I've got an email list. You can join that. I send out highlights of episodes. You can also respond to that too. I am on TikTok right now, so you can find me there. I've been posting some study tools if you're more of like a visual study person. And then I do have a free little study guide that you can download in the show notes. For some people, it's nice to have it written down in a little chart that you can have with you at the clinic. Just download it below in the show notes. And then if you are in the need for some CCUs, June's actually a very special month because MedBridge is celebrating their 15th year anniversary. So there are some huge sales going on right now. If you don't know who MedBridge is, it's basically a website that has tons of CEU courses for PTs, OTs, and speech, but I'm here talking to PTs, right? And they also, like if you're studying for an OCS, SCS, some sort of specialty exam prep, they do have a exam prep course built right into there. So really nice for getting used to being on the computer and answering questions and seeing where you're at. So with all that being said, I hope you guys have a great rest of your day, and until next time.